Welcome everyone to our June online patient forum. We have today Alison Berner. She's an academic clinical lecturer in medical oncology at Barts Cancer Institute and St. Bartholomew's Hospital. She's a specialized doctor in adult gender identity and the Gender Identity Clinic in London. Alison leads the UK Cancer and Transition Service at Chelsea Westminster Hospital. She's providing clinical advice for gender diverse patients with active cancer or genetic cancer predisposition. Her research focuses on improving cancer care for LGBTQ+ populations and sex and gender-based differences in cancer incidence. Today, Alison will be talking about improving cancer care for the LGBTQ+ community. Thank you, Alison, for joining us today. I know very much that you're very busy, so we're very lucky to have you today.
Oh, absolute pleasure. I really enjoy coming and doing lots of patient public involvement work. And actually, one of the reasons today is busy is because I have a 2-hour focus group tonight that we're leading to do with a piece of work, which I'm going to talk to you about. So, which is really nice. It's an absolute pleasure. And really thank you for inviting me. I will share my slides, which I'm hoping you can see. Yeah. So I first talked to you for around about half an hour with time for questions at the end, but as there is only 2 people who've come in as participants and then you 2 facilitating, if you just want to stop me and we do a general chit chat, that's absolutely fine. I'm cool with that. So you give me a lovely intro, so I don't really have to give too much of a background to who I am and what I do. But to suffice today, yeah, I'm wearing oncology hats, gender identity care hats, researcher hats, and I'm going to sort of talk to you about how we're blending those things together and the work that I do actually very closely with the Outpatients charity for LGBTQ cancer patients, and kind of why it's important and where we're going with the work. So this is sort of what I'm going to run through. I'm just going to talk about terminology because I think it's something that is constantly changing and often kind of up in the media. So I'm just going to run through that, why I think this is important and a bit about quality of care, what we know in the data at the moment, and then run through kind of 3 things that are kind of research driven and patient involvement driven around bespoke care, bespoke studies in LGBTQ populations, and then wider trial inclusion, and then just talk a little bit about what my next plans are. It'd be really interesting to hear people's thoughts on the kind of proposed research, and that's what's getting discussed tonight. So obviously there's the acronym LGBTIQ+, which everyone sort of struggles, I think, with the alphabet soup because it's expanding all the time, but actually it's really important to kind of recognise differing identities in this space and just to kind of, so we're all starting from the same place. So LGB, lesbian, gay, bisexual, we're talking about sexual orientation. T, we're talking about transgender or gender identity or gender diversity. The I is referring to the population that identifies intersex, and those people will have variations of sex characteristics, but not everyone with a variation in sex characteristics will identify as intersex. Q stands for queer, which is a reclaimed term, which can be used to cover sexual orientation or gender identity, and plus includes other identities, both gender and sexual orientation related. Sex is a genetically determined thing that refers to kind of hormones, reproductive organs, chromosomes, but it's not necessarily always something that's binary. And that contrasts with gender identity, which is about how someone lives their life and expresses the kind of norms, roles and behaviours around gender, either masculinity, femininity, both, neither, or a mixture of those things. Gender identity is not an ideology. It is defined by the World Health Organization. And when these 2 things don't align, we talk about gender incongruence, which is a condition related to sexual health in our ICD-11. And it's that sort of diagnostic label that we in gender identity services have to assign to provide care. But this is about identity and it's not about pathology. It's just that we have to use that. And the good example there is that you wouldn't say that someone who was pregnant was unwell, but they do still need medical services. And so that's the sort of example that I would give. And I'll talk about people being cis or cisgender. So that's when the sex you were assigned at birth aligns with your gender identity. And I'll talk about someone being trans when those things don't align. So a trans woman is someone who was assigned male at birth but identifies as female. And a trans man is someone who was assigned female at birth but identifies as male. And then non-binary people may have been assigned male or female at birth, but they identify as neither masculine or feminine. And it might be that their gender fluctuates, that they feel a mixture of genders, that they experience no gender at all. So why are all of these things important, and why do I spend my time on this? Well, actually, first of all, we know that increasing numbers of individuals are choosing to disclose a non-heterosexual sexual orientation to us. And when I say that choosing to disclose, actually, we believe that actually it's not that being non-heterosexual is becoming more common. It's simply that it's becoming more acceptable to discuss it. So we see this increasing disclosure in younger age groups. And we actually see the same thing in gender incongruence. So these were both data taken from the GP patient survey, which is one of the few places we're able to get this data because we don't have it in general recording in kind of primary or secondary care data. And sort of if you follow that sort of curve of distribution of people disclosing, it's, as you see, it's a kind of similar pattern. And so more people are identifying and telling us, which is great that people are choosing to tell us. But the problem is that as a community, we, and I as someone who identifies bisexual, identifies part of that community, still continue to experience bad patient experiences. So these are from several surveys that have been done in recent years with people witnessing discrimination, avoiding healthcare, having negative experience, not feeling they can disclose or be out to their healthcare professionals, and feeling that healthcare professionals lack an understanding of the specific healthcare needs of LGBTQ populations, of which there are several and specific to cancer, which I'll talk about. And here is in the National Cancer Patient Experience Survey, and this is old data because it's from 2016, but it's kind of mirrored in a lot of the ones since. I've just used the one that's been formally published. So people feeling that they were less involved in their treatment decisions, less likely that their friends or family were properly involved in their treatment decisions, and feeling like they get more unequal care as cancer patients. And this may not all be intentional. Some of it is actually discomfort on the part of the healthcare professional, not necessarily knowing or having the experience to understand how to include a same-sex partner in a conversation or talk about sexual side effects from cancer or things like that. But the outcomes are inferior. And so how does being LGBTQ affect kind of cancer care? Well, I kind of put it in these sort of 4 boxes. So one is stigma or discrimination. So people may experience a lack of access to healthcare or feel unable to seek healthcare for fear of discrimination, be unable to build trust with their clinician, and the clinician is unable to tailor advice to someone. So that might be to do with specific medical treatment. For example, for someone who's trans and on gender affirming care, it might be talking around fertility advice on chemotherapy. And so it goes all the way through different cancer types. In terms of cancer incidence and outcomes, we know that subsets of the LGBTQ population have higher rates of smoking, alcohol, and bloodborne virus infections like HIV or hepatitis. And some of that is driven by minority stress and discrimination, and those things are associated with more cancers. There are changes to incidence if you have gender-affirming hormones or surgeries, and that means that screening information has to be tailored. And there are also sex-based differences in non-sex-related cancers that we know about in other cancer types. So, for example, certain types of lung cancer are more common in cis women. And we need to know how to translate that across, depending on if someone is gender diverse. There's things that we do quite badly for everybody, really, like talking about sexual health and fertility in a tailored way, and we do that even worse for LGBTQ people. And then in terms of general support and end-of-life care, we need to know that we're involving the right people in people's kind of social circles and in their relationships, and we don't always do that if we don't ask properly. And there are particular concerns for trans folks around legal rights around death and burial, how their care will be continued. And we know that actually healthcare professionals are not up to the mark. This is some research I did a few years ago where we surveyed oncologists in the UK. consultants and trainees, and very few were confident in their knowledge, and around 3/4 felt they wanted more education. And although they felt it was important to know about sexual orientation, gender identity, they weren't feeling confident to ask people in their consultations. And it's how do we translate that into better outcomes for the population? How do we educate, and how do we provide all of the evidence to help support asking those questions as well, because people are more likely to ask the question if they understand why it's so important. So what do we know about cancers in these populations? Well, it's hard in the UK to gather the data. It's actually quite hard worldwide. So I've mentioned we don't record sexual orientation, gender identity or trans status routinely in our healthcare data. Where we do, it's sometimes coded in an unhelpful way. We may not have links to things like hormone prescriptions, which do change incidence, and we can't adjust for things like barriers to care. And we also tend to need to combine groups of people over a really long period of time. And obviously, if you're combined to get high enough numbers to get statistical differences, and things change over time. So actually interpreting what we see in the data is really complicated, which doesn't help us because the data isn't ideal. And I'm going to show you some examples of that. So, for example, this was some work done, it's quite old now, done in 2017, where they couldn't look in the cancer registry, which is where we look at to see if other groups are getting more or less cancers. So what they did was some clever data linkage using the GP patient survey to find out what cancers people said they'd had, and if they were over or underrepresented by sexual orientation. And so you can see here some of the ones that were more or less common. But we don't, that's just numbers. We don't necessarily know why. And we can interpret some of it. So we can understand why the ones that I've underlined here, Kaposi sarcoma, anal penile cancer, oropharyngeal, Hodgkin's lymphoma. So those will be linked to HIV, which is more common in gay and bisexual men. And so we think that that would be the reason, but we can't say anything there about sort of barriers to care or anything like that. And there are some that we don't necessarily understand why we would see more or less of. In the trans population, we tend to look for data from abroad. So the Dutch have a way of linking pathology, so tumours that have been removed from people, to their gender identity clinic. And we can see that in trans women, so people who are assigned male at birth, identify as female, taking hormones have about a 3 times lower breast cancer rate than cisgender women. And trans men have about a 5 times lower breast cancer rate. Prostate cancer is about 5 times less common in trans women than it is in cis men. And the reasons behind these, in the case of trans women, they're taking estrogens and testosterone blockers, which lower the breast cancer risk, raise the breast cancer risk, but lower the prostate cancer risk because of the way that those hormones work. In the case of trans men, they have a lot, but not all of the breast tissue removed. And so that's a big reason for the reduction in their risk. But some of it is probably also to do with genetic changes at the genetic level. And there's been some really neat research in other countries demonstrating the way that cells change. But there's only been one study and only using, I think, 9 patients. So it's really small. The problem we've got there is the Dutch use different hormones to how we do in the UK. So we're still trying to work out if this is about the right amount. In the US, we can use one of their databases to again look at these over and underrepresented cancers in the same way we did for sexual orientation in the UK. But here we don't know who were trans men and who were trans women. We only know if they were trans or not, because you've only got one box for sex or gender in the registry. So again, we see these higher rates of cancers related to HIV, human papillomavirus, which is the virus that causes cervical cancer, but also anal and oral cancers, and smoking. And we see lower rates of these cancers in organs that may have been removed in surgeries that trans people have. But more than that, we don't know. And the infographic on the left just summarises some of what we know from papers, but where we're pretty unclear on these kind of sex-related cancers that are particularly relevant for trans people, because some of them will be quite dysphoric to have, and people want to know how common they are and what effects some of these hormones are having. So what are we doing about it? Well, in light of a sort of lack of evidence, one of the things that we can do is provide a little bit more time to give bespoke care to patients, and to actually be able to appraise what little evidence there is and go over things in detail with them, and also start to collect data on how on the research questions we should be asking, because if you see everybody in one clinic, you start to pick up patterns. So I run something called the UK Cancer and Transition Service, which is a national clinic, an MDT. MDT stands for Multidisciplinary Team Meeting, where we not only see the individual, but we see all their clinicians all on one big online call. So we don't provide the direct cancer care. We basically liaise between all the teams, and we help them make decisions about what's best for the patient, because oncologists don't understand gender affirming care, and gender affirming care clinicians don't understand cancer. So I've dual trained in both, and we have lots of other expertise, and they all dial into a big meeting to try to put all the information together. And we plan to use that to develop some patient-reported outcome measures, and to work together with the patients in that group. And then also eventually, once we've got enough experience, to try to develop some guidelines and to work with other countries to do that. And we currently work around about twice a month, and we've had some grant funding from a pharma company to buy a nurse for us to provide some additional support to patients, which is really important. And we've been running for about 2 years, and our referrals are rocketing, which is great. I also work really closely with Outpatients, which is the LGBTIQ plus cancer charity. It was actually started here as a charity called Live Through This. It started providing face-to-face peer support over in the Maggie's Centre, and it's now grown into a huge cancer charity, which at a time when sadly lots of charities are struggling, is doing really well, providing peer support, working with other charities, providing tailored information, doing kind of policy and advocacy. And I work with them on all of the patient and public involvement for things like UCATS, which I mentioned, and then a lot of the research that I'm going to talk to you about. And I try to we try to bring patient voices into the centre of all of that. And they're also very good at helping to signpost people to inclusive research and things like that when they know it's going on, and they also are involved in research themselves. So to talk about some of the bespoke studies that we've done with here in particular with the trans and LGBTQ community, because sometimes inclusion in wider research has not been it's been much more difficult because of mistrust in healthcare for some of the reasons I've spoken to you about. So when I first started working in gender affirming care, it became very obvious that a lot of the trans men I was seeing were not going for their cervical screening, and that's backed up in the data. So a lot of trans men, certainly around 2/3 or more, will keep their cervix through life. They won't have surgery to remove it. And they were being turned away from cervical screening, or the laboratories were getting the results and seeing a male name and not processing them. And our call and recall system in the UK can't call you if you're registered as male with a GP on your gender marker. So we did a survey, a qualitative survey across the gender identity clinic waiting list and across a sexual health clinic that sees trans people, and we found all of these barriers and facilitators. So it's not just about it being part of your body that you don't associate with. Actually, it's that the information sheets that all look female centered, and actually that your provider doesn't understand anything about your health. But actually people felt that if they could either get a good GP or a good trans specialist service, then they would be more likely to engage. And they were also very interested in having tailored information and also the ability to take their own self-screening test. And so we used these ideas to then go and think about what we should do as next steps. Joe's Cervical Cancer Trust, which is sadly closed, produced some tailored information, and they supported this study, which was great. And that is how Self-T was born. So Self-T is a study that's currently running, and it's funded by the National Institute for Health. So that's Sarah Jackson who funds it. She's my co-PI. And that's Stuart, the founder of Outpatients, who's also been a key kind of investigator in getting it off the ground. So what we're doing is actually studying self-swabbing for HPV, which is the virus that causes cervical cancer, as I mentioned. But because it also causes lots of other cancer types, we're testing for HPV at lots of different body sites, and seeing how people feel about testing for it, whether it's more feasible to do testing in clinic or at home, and working out whether there might be a relationship to the hormones people are using in terms of how well it works. And then we're also consenting people for us to be able to use those samples for other research related to this in the future. And the idea is that we will then expand this study. So it's currently open at 3 sites. We've recruited, I think, just over 20 of our 100. We've been open since February, end of February, beginning of March. So we're doing quite well. And that fully co-produced, so we've got a community advisory board who we meet with regularly about things like advertising, and they've reviewed all of our materials, and it's called a community advisory board because that's what they call it in the US, and Sarah's from the US, and they've been great. And actually the study would not have got off the ground without them, because there are things like actually the size of the swabs that we use and the colours that they are and our advertising and where to go that mean that if we'd have not asked our community advisory board, probably this wouldn't have worked. And we're not the only people doing this. So this is LGBTQ ACEs. So ACEs is a study that's looking at self-sampling in Manchester. And it's actually looking at self-sampling across lots of hard to reach groups. So including people with disabilities, people from ethnic minorities, and the whole LGBTQ plus community. So not just trans folks. And actually what they've done, they did a survey, which I'm showing here, which is Jen's work, looking at how who might be interested. So you can see there are quite a lot of bisexual and lesbian participants, and that you see on the right whether they actually prefer not only a vaginal swab but a urine sample or their routine screening. And they've taken that forward to feed it into actually a wider pilot of urine or swab-based screening that's going to launch, I think, later in the year, but I can't say much more about it because it's still a bit under wraps, I think. And they're following up their survey with qualitative interviews as well. So this is, again, really responsive research that is so responsive to what the community want. So what are the other challenges we're focusing on? And this is a super secret squirrel thing at the moment, so don't mention to anyone. But so we're about to do some work in prostate cancer. So PSA is a blood test that we use to diagnose and monitor prostate cancer. It's lowered by medications that lower testosterone, which means that trans women who take estrogen and testosterone blockers will have a lower PSA. But no one's ever got a big group of trans women and measured it, which means that these women, when they're out and about to the GP and have a worrying symptom, and the GP measures the PSA, they don't know how to interpret it. And you can't just compare it to cis men with low testosterone because it's not the same situation, or at least we haven't got proof that it is. So we wanted to establish normal reference ranges. So we came up with the study Trans Pride, which is, I won't read you the full acronym there, but it's basically to determine a reference interval. So what we would expect for a healthy trans woman, her PSA to be. And we've just had funding for that. The call is not to be announced until September, so don't go telling your friends, but we've just had £280,000 to fund us to recruit 500 trans women over 40 across 8 sites in the UK, to take a blood test, to collect what information they're about hormones they're on, and then to follow them up to check they stay healthy. And then we will be able to determine these reference range intervals. And there's actually been a similar study looking at other general biochemistry, which has been run in Clinic Q in South London, called Trans Rights, and Devon, one of the study investigators on that, is also on this study. And again, we co-developed this with a PPI group, which I think was integral to us getting funding, and we also have trans researchers on the group. And then the last bespoke study, which is not yet in existence, is around endometrial cancer. So we have this challenge that we know that cancer of the lining of the womb, called the endometrium, is more common in cisgender women with high androgens. So some people happen to have high androgens by chance. Some women have a condition called polycystic ovarian syndrome that makes their testosterone high. And because of that, testosterone can be converted to estrogen in the body, and high estrogen levels are associated with more of this cancer of the lining of the womb. And because of that, trans men who take testosterone, there have been worries that they have more endometrial cancer, but there's been no conclusive evidence. And part of that's been because the studies that have been done have been poorly conducted, and partly because it used to be that a lot of countries mandated hysterectomies for trans men at a really young age, so like the age of 25. So you're never going to know, because young people don't get endometrial cancer. And we don't screen cisgender women, even if they're at high risk, but that's probably because we don't really understand how to risk stratify properly, and because endometrial cancer is less common than, say, breast cancer, for example. And so to try to work out what we should be doing for these people and whether we should be screening them or not, because different people are doing different things, we came up with another PPI project, which has just been funded. So this is Make It Personal. So it's asking people's perspectives on this risk and screening. So it's a two-part focus group. So we're going to recruit people from this population to explore what they think about the acceptability of screening, whether it's something that the community feels should be investigated. And that's been funded by the City of London. And so depending on what people say, we may or may not kind of go forward with a project grant for that. So what about inclusion in general trials? Because there's some really specific examples that I've given where there's data we don't have, but actually we need to just work out if medicines work for everyone. And we know that we've historically recruited really poorly from different minority groups into trials. So trial participants tend to be white, well-educated, heterosexual, cisgender people. So there have been some reports about what we should do to help encourage LGBTQ inclusion in research, and we try to work by this in the group that I run. And there's some really important things that I think are important for everybody. So around not making assumptions, checking how people want to be addressed, being really inclusive. But there's other things like for particular groups, and I think it's important for any minority group that has been taken advantage of in healthcare or research in the past, that people want to know that they're being really valued and that there's people on their side on the team. So actually there's additional things that we do, like providing a chance to talk to us directly as study investigators, ensuring all of things to do with co-production, and we try to kind of follow all of these. And we're not the only group trying to do this and encourage general trial inclusion. So actually we are, there's been some work in the States. So on the left, this is from a pharma company that have produced a video and have made a big point that their latest prostate cancer study is inclusive of trans women. And this is from Ash Alpert, who is a trans academic in the States, who has published a paper on how to address these barriers in clinical trials. And we're trying to bring this work into the UK. So myself and Stuart from Outpatients are working with a number of pharma companies. And then we're also trying to work with the ECMCs, which I'm going to show you about shortly. So I've got some future plans. I'm very passionate about improving this. And so what I just want to finish on is what I'm intending to do next with some of this work. So ideally, I want to move out of this kind of screening and risk space and be able to offer evidence-based management for the trans patients that I see in my UCATS clinic, because currently I don't necessarily have the same level of evidence to offer them about how to manage their hormones in breast cancer as I do when I sit in a breast cancer clinic at Barts and talk to a cisgender woman. So there are three things that we want to do. So one is to look at a big US-based big data database, which is used. Basically, it has better information because it's how people get paid. And so because they have a paid for system there, we can actually probably get some better data out on health outcomes for trans people on cancer treatment than we're able to do through NHS data at the moment. But because there are these differences between the US and the UK, I think we also need to have an observational study here in the UK. So from the UCATS clinic, we're planning on rolling people into an observational study where we can collect their clinical data and also biobank their samples. And it will be entirely optional. And obviously it won't be as big a data set as if, say, we could get all of this information out of the NHS. But sadly, the ability to record this in the cancer registry is a political decision, not one I can influence. So until that happens, we're trying to do this through a small observational cohort, and to be able to at least provide a bank of tissue for if people want to do the sorts of molecular studies that I mentioned, which currently there just isn't enough material to do. And then the final thing we're doing, which Maria is helping with, is to investigate how well LGBTQ people are included in cancer clinical trials. So are we even asking about identity? Do we talk inclusively in patient information sheets about things like fertility and contraception? I'm working with a master's student to evaluate that. And then we're going to create a kind of audit tool that we use in this ECMC, and then that we roll out across, hopefully across a wider network. So maybe the ECMCs, or maybe something like the National Institute for Health Research. And I'm pleased to say that QMEL have also funded some PPIE for that. So that's what we're running tonight. So that's Transcript, where we've got a group of trans folks with active cancer or have had cancer in the past, who we are actually not even going to talk about the project plan with. This is my project plan, but actually we're just going to hear their views. And actually, if I need to actually go scrap this and go back to basics with it, then I will. So the first focus group is just to hear their views and experiences and what they feel are the priorities, and then to come up with either projects that are related to the outline I've given, or to come up with different kind of work packages to address what this group think are important. That's it. I'll take questions. I think at least one came up in the chat.
Yeah, I think Vicky can't use the microphone and she texted on the chat. Let me just read it. I would guess that there is a distinctive discrepancy in both self-disclosure and accepting treatment amongst different cultures and ethnicities that present with cancer that has been measured, or is this anecdotal?
Yeah, no, it has been measured. There's been some great work, particularly around Black women with breast cancer, for example. You may be aware that Gilead, for example, showed a video that's been done with that. A lot of that's been done in the US. But yeah, there's lots of work that's been done, particularly around ethnicity, some more around culture. Not enough. I think particularly not enough because particularly not enough by clinical academics, because a lot of particularly oncologists are not encouraged to go off and do more qualitative research in their careers, which I think is a shame, because we're in a really good place to be able to see something in the clinic that we feel is a barrier and then take that out into the community and ask about it. But there's more and more around that, for example, at the big cancer conferences at the moment, and then also a lot around there's a lot around financial toxicity as well, and around being of a low socioeconomic status. If you're thinking about disclosure with as well of LGBTQ identities, yes, we know that actually queer and trans people of colour are a particularly vulnerable minority to not having their healthcare needs met. So, for example, I was at a recent conference and we had a patient advocate who actually leads a big charity there, and I know she won't mind me sharing the story, but she's Black and she went to A&E with her first cancer diagnosis and was turned away. She was accused of drug seeking because she was asking for pain relief for her cancer. And then when she eventually had her emergency surgery, she woke up and she's a lesbian woman. She asked for her wife. And she was in a state that has a lot of anti-LGBTQ feeling. And she woke up and asked for her wife, and the healthcare professional turned to her and said, I don't know where you're married, but you're not married here, which was obviously quite a tough thing for someone that's just woken up for emergency surgery for cancer. So I think we are measuring it, but there's way more that's actually anecdotal that we probably need to measure, but it's very difficult because probably the places that need that the most is the most difficult place to measure it. And some of it is also micro, so people don't even feel they can talk about it because it feels immeasurable or it feels subtle to them as individuals. Oh, that's an excellent question, Vicky. So is qualitative research inadequately funded and resourced, or are people just too busy to prioritise it or fit it into their projects? I think there's some great funding out there for it actually now, particularly through places like the NIHR. I think all research is challenging within the NHS. So I don't think it's too busy to prioritise that in particular. I think we're encouraged not to do usually purely, and this is me speaking as an oncologist, I think it is different for different healthcare professionals, but we're encouraged not to do anything that's mixed. So you usually tend to do a lab project or a clinical trials project or a qualitative project. And I think, unfortunately, sometimes there is a bias that qualitative research is seen as somehow less robust for a doctor to be doing. I don't think that's correct. or it's not funded well because people actually do it on the side. So a lot of my qualitative research was done on the side whilst cheating on my very lab-based genomics PhD because it interested me. I do think that's changing. I do think it's better for non-doctor healthcare professionals, but that shouldn't be right. There's no reason, because of the type of healthcare professional you are, what sort of research you should do. But I do think it's improving. There's been some great things, like initiatives that went out, did qualitative work and realised that it was best to put up breast screening posters for South Asian women in sari shops, because that is the place that people are undressed and talk about these things.
That was a good question. Neil, do you have any questions?
I would if I could.
I think Vicky has more questions.
We can hear you.
Can you hear me?
Yeah.
I was just going to say, I mean, this is very new to me and it's very interesting, but when we review our documents for the trials, do we have anybody who's got that angle? Who's looking at it from an LGBTQ angle?
So actually we don't currently as we speak, and this is why Alison has also kindly presented to us a project. I think number one, we don't have within our team just because we haven't had the chance, but also one of the points we want to check is there's not, when you review the documents, there's not much that captures any extra information, and you've reviewed thousands of them.
Yeah.
So it's about like making these documents more friendly for everyone and more inclusive. Yeah. So this is one of the projects we're looking at, and you're absolutely right. And is, you know, you're already disclosing, Alison, how the documents are. It is absolutely true. Like, you don't have much information that kind of like prompt you to think about, you know, all these.
That's what made me think.
No, absolutely.
And when I do, I'll try and think that way as well.
Thank you so much. I think Vicky had another question. She's typing, but I'm going to read the last comment. I'm sorry, there are so few of our group here. Oh, yeah, there's a lot of COVID circulation and she's not very well. That's fine. No worries, Vicky. We understand. And I think today it's a very nice day outside. So we understand that we don't have that many today, but we are uploading this session online and we're sharing it with the wider network. So I'm pretty sure this session will definitely reach other patients. I think I have one question for you, Alison, and it's very focused to Barts, but if we have, if there's any way healthcare professionals here at Barts that we have to support any patient from the LGBTQ plus community, what are the resources we have available on our center?
So if you go to the Maggie Centre, they have all the documents from Outpatients there. So like flyers and things. I would definitely direct everyone to them because they are the national charity. There are Macmillan documents that should be in the Macmillan Centre and around the hospital and in Maggie's that have been co-produced with Outpatients when it was called Live Through This, because it's had a name change. And the peer support, hopefully we'll get going face to face, if not already soon as well, which is great. Also, the Maggie's and Macmillan Centre should have flyers for the UCAT service for any trans patients in particular. And then actually on the Outpatients website are lots of kind of signposting resources as well. And I'm always really happy to be contacted to help kind of signpost to things also, but the best place to start is the Outpatients website because they have resources for patients and for professionals.
That's fantastic. Thank you so much. I think Vicky was typing.
There is a local LGBTQ asylum seekers group that meets weekly. Do you anticipate being able in future to send speakers to similar groups to address their concerns? Yeah, I mean, I wasn't aware of that, and actually, I think these sort of very intersectional groups, I'm always very happy to make contact with, or to make contact with through Outpatients to hear their views about various things. I think these groups are really important, because actually a lot of the minority stress and cancer risk factors comes from intersectional experience. So the large number, for example, of HIV positive Black trans women, more so in the US, but also in the UK, happens because there are people that come to the UK and because of discrimination are forced into risky sex work through no other option, or that has been what they've been forced into in their country, and that's how they've contracted HIV or hepatitis. So there's all these kind of intersectional concerns. So yeah, I mean, I'd be very interested to make contact with that group and to see if myself or Stuart should make contact with them.
Thank you, Vicky. I think I can definitely put you in touch. I'm conscious of time and your clinic. I don't think there are any more questions on the chat. Neil, do you have any more questions?
No, thank you.
That's fine.
Thank you for being so welcoming, though, and the offer to keep these things in mind when you're reviewing all of the documents. I think with that, you know, not everyone, depending on the size, will be able to have every identity reflected in the groups that do these things. So that the goal of us working with this Kaya, who's a fantastic distance learning MSc student, is to produce something where NIHR have told me I shouldn't call it a tool because everyone produces a tool, but I'll produce the tool for Barts if no one else wants to use it, you know, as a bit of a kind of, are we thinking about this, just as a prompt, because none of us can, you know, I don't profess to be able to review something from the point of view of someone of color, right? I've had the privilege of being white my whole life. And it goes for everything. Like, you can't know what you don't know, but if you can have a prompt to think about it and say, well, maybe I should go away and check this, or it's helpful. So hopefully the work with Kaya, we'll be able to evaluate what's there and then come up with something, and ultimately come up with something that all PIs need to think about when they're designing studies and accepting studies and stuff like that.
Yeah, I think that's key to have some prompts. You're absolutely right. We can't really have on our patient and public involvement group a representation of each individual. But I think, like Neil mentioned, even just if we have a prompt to think about how would I feel, you know, I think that would be fantastic. So yeah, I think it's a really good project. Sorry, Neil?
It would help me if there was a prompt.
Yeah,
absolutely.
I'm the worst, aren't I? I'm white, middle class. I'm the worst person that can be to review it, really. And without a prompt, I'm stuffed, I suppose. Or I'm not even going to be thinking about it sometimes.
No, but at least you can. But you're someone who might be all of those things. But at least you're accepting to realise you know what you don't know, and that's half. Do you know what I mean? I do work especially with the trans community. I'm not trans, so I'm constantly having to check myself. And then also just wanted to acknowledge the other comment by Vicky in the chat is thank you so much for the work that you have done with in that group. That sounds like really hard work you were doing in Glasgow around asylum seeking and trafficked people. So yeah, just thank you for that work, because it's really important.
Yeah, thank you, Vicky. I will definitely put you both in touch, so if you can discuss further. Thank you very much, Alison, to taking time. I think it's been very interesting. I'm pretty sure we all have learned, and we can definitely design more prompts in the future to help our patient and public involvement group when reviewing certain documents. They have done a fantastic job helping clinicians designing, you know, the consents for the study. So definitely it's something we need to look at to ensure we try and represent everyone as much as possible. Thank you so much again. Hopefully we can have you next time. And if you ever need anything, we're all here to help you with your projects.
And I'm presenting Friday as well, right, to the team?
Yeah.
Yeah, and that's to the just to check, that's the internal trials team.
That is the internal trials team. So we can have Neil a bit more information to support the patients when they come to us.
Perfect. I'm just multiple talks this week, so I'm working.
I know.
So yeah.
Don't worry, just take it easy. We're very, very easygoing.
I never take it easy. That's my problem. You're very welcome. Take care, folks.
Thank you, and thank you, Vicky, for all the information. Bye. Bye.